So this is the thoughts I received for your talk. So this is what I tried to prepare from the previous speaker. And we're going to address the history of how synchrony has changed. We're going to address progesterone, which is the key in order to be able to ensure receptivity. The issues that come with progesterone that it's very important for endometrium, the receptivity in fresh and frozen embryo transfer, and of course, what to do in the cases of endometriosis and adenomyosis. As you see, we are not going to talk about surgery anymore. So in terms of history, well, Louise Brown was actually born after natural cycle. And the first time that in ART, that we achieved egg donation and we tried to transfer, it was in '84. Now, what was needed in order for the patient to be scheduled or synchronized for that embryo that will come from the fertilization of egg donation, you needed to have an artificial cycle, or you needed to understand how to make it work. And of course, you had to do artificial cycles, and actually at that time, the pregnancy rates that after egg donation was largely exceeding pregnancy rates in regular ART. What we learned that we can actually control for the endometrium, and therefore we can improve ART outcomes. Because by the time you would have the donor that was having a stimulation, but the recipient was only synchronized with the future embryo. So therefore she was not stimulated. And therefore there is this idea of, well, easy, you go estrogen and you don't go progesterone starting at the moment you have the best endometrium possible. But there were things that we not got right from the beginning, because, for example, in natural cycle, as shown here, you're going to have the LH surge, and progesterone will start, well, with ovulation, okay? And therefore, you have the best window synchrony for embryo and endometrium. What happened is that in a stimulated cycle, where you stimulate your patient to get those eggs, the ideal eggs, the problem is that when you give ACG, what happens is that you have, well, it didn't work as previously, but what you have is that progesterone will rise once you get ACG. So the moment you do the retrieval, you're already under at least 24 hours of high progesterone. And therefore, what happens is that you lose 24 hours from your window of implantation, which is actually 3 days. And therefore, what happens is that some embryos, depending on the state of development of the embryo, will fail to implant. Because you all know, I think, that when you go to blastocyst, you're going to get day 5 and day 6 blastocyst. The problem is that if you were to do a fresh transfer of day 6 embryos, you'll probably fail quite a lot. And this is something that has happened before, and it seems from what I hear that it's still happening now. And the problem is because of the shift of the window of implantation, all those of day 6 are largely outside. And therefore you have lower ART outcomes. And therefore, with this knowledge, you have now actually 3 types of endometriums. The normal ones that will have the best window for the same moment of the embryo, and you're going to have those pathologic where you have something that makes it always be either pre-receptive or post-receptive, like for example in endometriosis. And you have the synchronous where it happens sometimes, not necessarily every time. Or it can be induced by the stimulation that we are using to get the eggs. Now, this new concept where you have the window of vulnerability, where the window allows for the embryo to implant, and this is something that has been very reliable since the egg donation has begun in '84. And therefore, you have that moment of exposure to progesterone, where you can transfer reliably all your embryos. With this in mind, the concept of progesterone-inducing secretory endometrial the development of the endometrial glands and therefore being receptive. And this is the exposure after progesterone. Because if you were to take the the window of implantation, which takes 3 days, the longer you go off the window, the more miscarriage you're going to get. So the problem with ART outcomes where you are missing the window of implantation, you're going to get a higher increase of miscarriages. And the thing is that we looked at it, and the thing is that once the window closes, your embryo already has to be a blastocyst by that point there. The moment that decreases, your embryo is already out. And this is why it's very important that you transfer embryos in the best protocol possible. Because when you do frozen embryo transfer, because if you go back, it's one of the things that improved outcomes in ART by at least 25%. Even before PGT arrived, this actually happened because it allowed for embryos to be transferred, for example, for those of day 6, in the best moment possible. Of course, you will then argue, because I'm sure that in the room we have people that we're going to potentially give 5 days of progesterone before transfer or 6 days, and you'll wonder what is the optimal duration. Well, there is an incredible paper, because we have talked a lot about it, by the group of Mackens and Blockhill from Belgium, where they actually did a randomized trial where they had transfer blastocysts, day 5, after 4 days, 5 days, 6 days, 7 days. And there was no difference. And this is why it's important for you to remember is that window of implantation is very large. It's 3 days. It's very stable, okay? Given that we are transferring fresh embryos and we still get good results, and there is no need to exaggerate that idea of endometrial receptivity more with tests and other things that are completely non-proven, neither clinically validated. So in order to conclude on the control of the endometrial receptivity, I think that you have seen, and I think you have practiced, that estradiol and progesterone treatment are quite reliable, and that the problem that arose recently is that actually vaginal progesterone that was believed to increase the levels of progesterone actually has been proven to be not reliable at all times, and that actually recently there is an idea that the levels of progesterone in the blood are relevant because they are necessary for the immunotolerance. And of course, nowadays, when you are talking about freeze embryo transfer, you're going to mention that probably there is a high increase of preeclampsia and a high weight of delivery. But the problem is that all these data that you and we have recently read were done in vaginal progesterone cycles, because there is a difference between the two groups, Europeans and Americans, that in Europe we use quite a lot the vaginal progesterone, and actually it was quite promising because of the first uterine passage. Nowadays you have tons of different types of progesterone that you can use. Recently there are a group from Peter Humiden who are trying to use rectally, okay? But you have tons of them. But the idea is that you have injectable and you have vaginal. The difference between the vaginal and the injectable is that the vaginal is a passive absorption, so you cannot control for that. And historically, of course, the first described with the idea that if it doesn't hurt, it doesn't work, is the intramuscular, which is still used in the US quite often. And of course, the vaginal. All the rest is just variations. Now, with respect to progesterone, no progesterone product has been validated in frozen embryo transfers. And we know now that circulating progesterone levels matter and that pregnancy rates are equivalent. So the protocol that you are using as today has not been shown to be inferior to the other. The protocol of the embryo transfer is designed just to ensure that window of receptivity, nothing more. So protocols cannot increase pregnancy rates. It's just a matter of programmation and synchronization. And of course, all the debate started when they started to push Crenon as a vaginal product and so forth, and they had a good hope for a good outcome. But then again, when the European lab tried to put in the US market the vaginal progesterone, they failed quite badly because they did the RCT, and they have, actually we had 3 groups. You have intramuscular, hybrid, meaning that you give one intramuscular and one vaginal, and you had vaginal. And this 3-arm study have shown that vaginal progesterone is simply not enough. Yet we are still using it in Europe quite often. And then the question that came after was, why does it matter? Why the vaginal, apart from the absorption, does not work as injectable? It could be that there are systemic effects that are induced by the injectable progesterone and by those high levels of progesterone that you can have that can actually be an immunomodulator. So probably when you are talking about immunology, we should probably use maybe injectable progesterone other than just trying to invent new immunological factors. So it should be that you should rely on what has been proven so far. So in terms of progesterone levels, well, when you are going to use a natural cycle, which is in fashion right now, you don't actually need for exogenous progesterone. But in terms of when you do artificial cycles, no one really knows how much, because the problem is that what we know from the data that actually more than 1 out of 3 patients were below the cutoff, ideal cutoff of 10 nanograms. So this happens in natural cycles, okay? And also, another group by Elena Labarta has shown that when you have a lower progesterone than 9.2 before the embryo transfer, well, your results will be quite low. In this case, it was 8.8. And of course, they used own eggs and donated eggs and embryos with PGTA, where outcomes were quite impacted by the lower levels of progesterone. And therefore, in donor eggs, they found 80%, and patients that used own eggs and donor eggs, they had 80% lower results. So this is very important. Of course, that afterwards, it came with a solution. Well, what if we do a rescue of the luteal phase? And it showed that the rescue technique works quite oftenly. And this is why nowadays we are looking for progesterone. But I will just want to stress, this is starting like 2017, 2018, not before. We are not even looking for progesterone before levels, not even in natural cycles or frozen embryo cycles. So it could be that when we talked about RIF has evolved quite a lot. And it's very important that the practice has to be adapted to what we use today. Another paper of Predomelo showing that vaginal progesterone is insufficient to support luteal phase. And of course, there are other factors that can hamper the levels of progesterone, as mentioned by overweight, the time when you, for example, that can impact the absorption and so forth and the values. Also, history of low progesterone. And recently, you're going to have a paper showing that actually 25% of patients have repeatedly low progesterone levels, even though you're providing luteal phase support with vaginal progesterone. In terms of fresh and frozen embryo transfer, right now, we all know that our ART outcomes have improved by having more oocytes. The problem is by obtaining more oocytes, you're probably going to hamper the endometrium. And this is a big study showing that the freeze-all rate is highly superior than the fresh embryo transfer rates when you have this. Also, you have to know that this is something that we looked for, where sometimes progesterone rises because you have a higher numbers of eggs. And therefore, those great patients, potential patients, will actually have higher levels of progesterone in the natural cycles, and it's related to the numbers of oocytes that you're going to get. Another thing that is very important going further into understanding why endometrium is always the scapegoat and why the patients fail is because sometimes we have older patients. So in my case, all our patients are quite older. And here, above 35, you're going to have 46% of embryos which are going to be day 6. The problem with that is that if you transfer them fresh, or for example, you transfer blindly at day 2 or day 3, you're never going to know whether they will be at day 5 or day 6, right? Therefore, if you do a fresh transfer of day 2 and day 3, you're potentially throwing away half of those embryos because, let's face it, most of our patients are above 35 years old. But if you do a cryocycle, whether you do it natural or artificial, you're going to have more or less the same outcomes. I think we can honestly say there is ample evidence that actually endometrial receptivity is impaired when you do ovarian stimulation, because once you go over that physiological level of, let's say, 1,000 estradiol, those endometrial glands will suffer. And therefore, you can cause yourself a resistance to progesterone due to the incompatibility of estrogen receptors and estrogen receptors of progesterone. And also, it's very important to mention that the endometrial receptivity in natural cycles or fresh cycles is as good as your cycle is. Because if you went high on estradiol, if it took too long, you stimulated too long to get those oocytes, your endometrium will suffer, and the endometrium is not as robust as we might think. Now, and I will close with this one, it's very important to not forget that although we are shifting nowadays to a more natural, which is quite normal, cheaper, more robust treatment for frozen embryo transfers, there is a problem that remains with those patients with adenomyosis and endometriosis, where before we were counseling them to block the ovarian function in order for them to succeed. The problem is that all that we have showed you yesterday, Monday, are data that was obtained in artificial cycles. So everything that was shown yesterday was controlled in the same protocol. What happens in a natural cycle is anyone's guess. Because the problem is that given if you were to believe the data that has been shown that is probably less than 5%, there is a problem because those studies never control for endometriosis, adenomyosis. Although this is a pathology that is quite often, 30% at least for endometriosis and 10% for adenomyosis. The problem is that if you look to the data, well, actually, some of them actually quite got successful with HRT cycles. For example, if you have a disorder of implantation of 10%, it will impact your population, 27% in the first population, and then when you do the second transfer, it's going to be 55%, will be with the same problem. So this is the concept of enrichment of the population that actually was shown yesterday by Barish. So if you were to have a disorder that repeats itself, by the end, the population will be majority. So if, for example, in endometriosis patient, in those cycles there will be a problem, well, this patient will never work because it's more than 55%. They all have this pathology because it will mean that they have been enriched by each cycle. And that a fourth embryo transfer will be quite low. And this is the paper that was shown prior. Now, I think that in case of endometriosis, you have to take into account that we do not have the data yet to understand what happens in natural cycles. And therefore, probably for those patients, you still have to do artificial cycles for the moment. And I provoke people to do research on the topic. Because I just want to recall, for most patients with adenomyosis and endometriosis, we have offered them several medications that were all suppressive of the ovarian function. And therefore, we know now, given the data that we show, that in these cycles where you suppress the ovarian function, and the endometrium is quite performing very well. So to conclude, I think that you have to treat endometrium as something that renews itself every 12 months, that potentially some pathologies or disorders of the endometrium can fix themselves on their own. Also, I would like to stress the fact that since the 80s, we are more or less doing the same thing, and nothing hasn't changed incredibly, and the results that we have obtained in artificial cycles were quite high. So I only stress that before we are indicated that the endometrium is the problem, we should wait and be careful to have high levels of data, of evidence, before doing so. Thank you very much.